Good day, everyone. Today, we are going to discuss a very important and clinically relevant topic in surgery, which is skin, with a subtopic of wounds and ulcers. This topic is extremely important because almost every patient we encounter in clinical practice will have some form of wound, and understanding why some wounds heal while others become chronic ulcers is a key to proper management. Let us begin with the concept of a wound. A wound is defined as a break in the continuity of the skin or underlying tissue due to an external or internal injury. Most wounds are acute, meaning they occur suddenly, and the body immediately initiates a well coordinated healing process. This healing process is not random, it is highly organized biological sequence involving multiple cells, mediators, and structural proteins. Immediately after a wound occurs, the first phase that begins is the hemostasis phase. Here, blood vessels constrict to reduce blood loss and platelets aggregate to form a clot. This clot is not just for stopping bleeding, it also acts as a scaffold for incoming cells that are essential for healing. Platelets release important growth factors that signal the next phases of repair. Following this is the inflammatory phase. During this phase, there is vasodilation leading to redness and warmth. Neutrophils are the first cells to arrive and they play a crucial role in killing bacteria. They are followed by macrophages, which are extremely important because they not only clear debris but also release cytokines and growth factors that regulate healing. If this phase is excessive or prolonged, it can delay healing and predispose to chronicity. The next phase is the proliferative phase. This is where actual tissue repair begins, and the fibroblasts produce collagen, which gives structural strength to the wound. At the same time, angiogenesis occurs, meaning new blood vessels are formed to supply oxygen and nutrients. The wound bed at this stage appears as healthy red granulation tissue. Epithelial cells migrate from the edges and start covering the wound surface. Finally, we have the remodeling phase. In this phase, the collagen was initially laid down, is organized and strengthened. However, it is important to understand that the healed tissue never reaches the full strength to the original tissue. It usually achieves about 70 to 80% of the original tensile strength. Now, although this process seems efficient, several factors can interfere with it. Local factors such as infection, presence of foreign bodies, and poor blood supply can delay healing. Systemic factors like diabetes, malnutrition, anemia, and advanced age also play a major role. For example, in diabetic patients, there is both neuropathy and vascular insufficiency, which significantly impair healing. Clinically, a wound typically presents with pain, bleeding, swelling, and redness. If infection sets in, you may notice pus discharge, foul smell, and fever. Proper evaluation of a wound includes assessing its size, depth, location, and presence of any foreign material or necrotic tissue. Management of wounds follow a very systematic approach. The first step is always cleaning the wound, usually with normal saline, to remove dirt and reduce bacterial load. This is followed by debridement, which means removal of dead or non-viable tissue. This step is crucial because dead tissue acts as a medium for bacterial growth and prevents healing. Depending on the condition of the wound, it may be closed primarily using sutures, allowed to heal by secondary intention, or closed later after infection control, which is known as delayed primary closure. Infection control with antibiotics, proper dressing, and tetanus prophylaxis are also essential components of management. Now, let us move on to ulcers, which represent a failure of normal wound healing. An ulcer is defined as a chronic break in the skin or mucous membrane that does not heal over a prolonged period. The fundamental difference between a wound and an ulcer is that in ulcer, the normal healing process is disrupted continuously. The pathogenesis of ulcer is centered around poor tissue perfusion and persistent injury. When there is reduced blood supply, tissues do not receive adequate oxygen and nutrients. This leads to hypoxia, cell death, and inability of the tissue to regenerate. In addition, persistent inflammation and infection further damage the tissue, creating a cycle of non-healing. There are several important causes of ulcers. Vascular causes are most common. In venous ulcers, there is venous insufficiency leading to pooling of the blood, increased pressure, and edema, which ultimately reduces oxygen delivery to tissues. These ulcers are typically seen around the medial malleolus and are usually less painful. In contrast, arterial ulcers occur due to the reduced arterial blood flow, often because of atherosclerosis. These ulcers are very painful, have a punched out appearance, and are commonly seen on the toes or pressure points. Neuropathic ulcers, especially in diabetes, occur due to the loss of sensation. Because the patient cannot feel pain, repeated trauma goes unnoticed, leading to ulcer formation. Pressure ulcers, also known as bed sores, occur in bedridden patients due to prolonged pressure over bony prominences, leading to ischemia and tissue necrosis. Clinically, ulcers present as non-healing lesions with varying degrees of pain, discharge, and surrounding skin changes. A very important part of clinical examination is describing the ulcer in detail. You must look at the edge, floor, and base. For example, a sloping edge indicates a healing ulcer. A punched out edge suggests an arterial ulcer, and undermined edge is seen in infective conditions like tuberculosis, and an everted edge raises suspicion of malignancy. Investigations are directed towards identifying the underlying cause. Blood glucose is essential to rule out diabetes. Doppler studies help assess vascular status. Wound cultures identifies infection, and biopsy is crucial if malignancy is suspected. Management of ulcers is more complex than wounds because you must treat both the ulcer and its underlying cause. General measures include improving nutrition and controlling systemic diseases. Local care involves cleaning, dressing, and debridement. Specific treatments depend on the type of ulcer. Venous ulcer require compression therapy to improve venous return. Arterial ulcers may need surgical intervention to restore blood flow. Diabetic ulcer requires strict glycemic control and proper food care. Pressure ulcers require frequent repositioning of patient to relieve pressure. Advanced therapies such as skin grafting and negative pressure wound therapy may be used in non-healing cases. One important modern concept is maintaining a moist wound environment as it promotes faster healing compared to a dry environment. Before we conclude, remember this key clinical principle. Whenever you see a non-healing ulcer, do not just treat the surface. Always think about the underlying cause, whether it is vascular, diabetic, infective, or malignant. To summarize, wounds are acute injuries that generally heal through a well-organized process, whereas ulcers are chronic lesions resulting from failure of this healing process. Understanding the mechanisms, identifying the cause, and applying a systematic approach to management are essential for effective treatment. Thank you.